Hello, dear friends and colleagues. I'm Dr. Sharmili Sinha, Senior Consultant Critical Care from Apollo Hospital, Bhubaneswar. And we are here to present to you yet another episode of ISCCM Vodcast. Here we try to bring along topics for discussion which are of clinical importance. And we get eminent experts in one particular field to throw their opinions and ideas regarding that particular topic. Today we have Dr. Muralidhar Kanchi, Senior Consultant Critical Care and Director Professor from Narayan Hospital, Bangalore. He has decades of experience in cardiac ultrasound and has played a pioneer role in spreading education and training in the field of ultrasound, mainly cardiac ultrasound. And along with me, we have my colleague Dr. Ranajit Chatterjee, Senior Consultant and in charge intensive care from Swami Dayanand Hospital, New Delhi, who will be hosting the show. So over to you, Dr. Ranajit, for the questions.
Really a pleasure. I think both me and Sharmili will be honored for that. And as you know that over the last 30 years, the intensive care has gone through a galaxy of changes actually. A lot of gadgets has come and it has revolutionized the practice of intensive care. One of the most important of them is the ultrasound and cardiac ultrasound or echocardiography to be precise. So how do you think that cardiac ultrasound has made such an impact to the clinical care? So what is your opinion about this?
Thank you and good evening to everyone present here and all the participants. It's a great pleasure to be a part of this program. First of all, I would like to thank and congratulate the ISCCM for bringing out this educational activity. Coming to the question which was asked about what is the change brought about by ultrasound in the intensive care units, particularly in terms of cardiac ultrasound. As you are aware, ultrasound in ICU is a game changer. It has changed the way we treat the patients at the bedside, and the main advantages of ultrasound or the use of echocardiography in the ICU is that it is non-invasive, it is real time, it is safe, and you can image the heart, lungs, vascular structures, abdomen. You can screen for DVT, that is the deep vein thrombosis, and also you can look at get some idea about the intracranial pressure by looking at the optic nerve sheath diameter. There are several ways it can be used in the intensive care to the benefit of the patient. The best advantage, it is bedside and it can be learned to be fairly quickly, and it is very useful in cardiac settings for rapid assessment of the cardiogenic shock or hypotension, fluid resuscitation, and detection of pneumothorax or pulmonary edema. And it also has a major role in placement of lines like central line and vascular cannulation needed for cardiovascular support, for example, in extracorporeal membrane oxygenation therapy. So these are all the various things where the ultrasound has made its way into the ICU care of patients.
Yeah, thank you, sir. I think it is really revolutionary.
Oh, great.
So, having learned that, so would you like to throw light on how a doctor, a junior doctor who is not so senior, who is working in emergency or critical care, what are the parameters actually would you advise to look for in the hours of resuscitation?
Very, very nice and pertinent question. We need to know what the junior physician should be capable of in the bedside, at the bedside in a critical care or emergency situation. What I would like the person who is on the bedside to know is how to know the cardiac activity, how well it is functioning. Is it hypocontractile or is it full? That is about the volume status, or is it empty? When it is empty, you see the kissing papillary muscle sign in the LV short axis view, where the two papillary muscles are touching each other. And I also would like him or her to know the B-line counting to be able to diagnose pulmonary congestion and pulmonary edema. Pneumothorax is again another important area where I would like the person on the bedside to know how to check for lung point, and also the other aspects of patient care in terms of valve function, if it is possible, whether the valves are working all right or they're leaking, it can be a benefit to the patient.
Right, sir. Thanks.
Stethoscope, the age-old stethoscope, was first discovered way back 200 years ago by Lennox. Do you think now it will be replaced by the ultrasound probe? What is your take on it?
It's an interesting question again. Whether the ultrasound probe will become a new stethoscope is always a question mark. My answer will be both yes and no, because after inspection, palpation, percussion, and auscultation, ultrasound comes the fifth modality of patient examination. And I insist that the clinical skills of inspection, palpation, percussion, and auscultation should not be forgotten. And ultrasound should be used just after auscultation to confirm the findings of the clinical examination. And I'm sure in the coming years, the ultrasound will become a common tool, just like a stethoscope, to be used in the emergency areas, critical care units, and in the operating rooms. That would be my response to this question. I would like the clinical skills to be retained. At the same time, take the advantage of technological developments so that the patient gets the best out of both.
Writing off stethoscope now.
Yeah. If you are only relying on the ultrasound, your clinical skills may come down, and you may not be able to appreciate. Suppose you don't have a ultrasound machine in a particular situation, then you'll be stuck without being able to tackle what is the problem.
All right. So that means ultrasound is a complement. It will complement what our clinical judgment, isn't it?
Complement and confirm and
Confirm.
strength the clinical findings, and you can always match it and then come to a good conclusion.
All right. Very interesting question that I'm going to ask you about the fluid responsiveness. So, how do you think that cardiac ultrasound will help us in fluid responsiveness? We know many things to be seen, but which are the salient points that you want to touch here?
Fluid responsiveness is a very, very vital issue in intensive care units, because when the patient is hypotensive, we need to know whether it is because of hypovolemia, or is it a contractility problem, or is it cardiac tamponade. We need to identify the type of shock. So here the fluid responsiveness is an important component of our endeavor to find what is the problem with the patient. Here, the cardiac ultrasound comes into picture in the sense that when we give fluid boluses, if the LVOT VTI rises by about 10%, it indicates that the patient is fluid responsive. This is one way to do it. The LVOT VTI is usually looked at when are using the transthoracic cardiography, using the apical 5-chamber view, taking care that the Doppler beam is exactly parallel to the flow of the blood, and the sample valve volume is placed in the LVOT, and the VTI, that is the velocity time integral, is determined automatically by the machine. And if there is increase in the VTI by about 10%, it should indicate that the patient is fluid responsiveness. Other methods of determining the fluid response.
I mean, you want to say that after doing a PLR, excuse me, Dr. Murli, you want to say that we do a PLR and then we see the VTI?
Yeah, PLR or fluid bolus I mentioned. PLR is quite good enough. I think PLR may be a better choice.
Or fluid bolus.
And also, look at the IV collapsibility and distensibility. Collapsibility in spontaneous breathing subjects, and distensibility in ventilated patients. And looking at the maximum and minimum diameters and getting the index, you will be able to know whether the patient is hypovolemic or euvolemic or hypervolemic.
I just want to say this because I have seen that my residents sometimes, even the consultants, sometimes struggle to get that VTI because you have to take the very absolute straight line. Maybe the
Yes.
angle should be around not more than 10 degrees. It's easier said than done, actually. So, can we have an alternative? Like, can we see the carotid VTI?
Yes, certainly. What you said is absolutely correct. The to be able to get any meaningful value, because the Doppler principle base is based on the frequency shift as the blood is coming towards or moving away from the transducer, in contrast to the 2D echocardiograph where the beam has to be perpendicular to the structure you are interrogating. So here it has to be exactly parallel. And if you are unable to get the LVOT VTI, so certainly you can look at the carotid artery blood flow and determine the VTI there, and then make decisions, reasonable decisions on the volume status by giving either the fluid bolus or the PLR.
So that's quite interesting to know how cardiac ultrasound is being helpful in initial assessment, then assessing fluid responsiveness. Um, there is a lot of noise and discussion about artificial intelligence now. It is everywhere. Every sphere you go, one of the talks is on artificial intelligence. So coming to artificial intelligence and ultrasound in critical care, do you think it's going to be a reality soon, or is it something we need to still wait for in the coming times? What's your opinion?
Yes, yes. This artificial intelligence is already happening, and it is going to take a greater role in intensive care management, especially in terms of echocardiography and ultrasound, because it enhances diagnostic accuracy, and most importantly, it removes the inter-individual variability. So, and also relative novices can perform the echocardiography or the ultrasound and get reasonable information, because if the view is not optimal, the machine itself will prompt the performer to adjust the probe in such a manner that you get optimal image. Once you get the optimal image, getting the precise information from that image is quite reasonably accurate, and we have demonstrated this in many patients. In fact, in two of our publications, we have demonstrated that the values obtained by the clinicians who have been trained in echocardiography for 4 weeks are as good as those obtained by trained sonographers who have been working in this field for several years with the use of artificial intelligence.
That's something great and exciting to know.
All right.
And how can it be used to measure cardiac output?
Cardiac output, the echocardiography can be used to measure the cardiac output in at least 2 ways. Cardiac output is basically stroke volume times the heart rate, and cardiac index is the cardiac output divided by body surface area, which is about 2.4 to 4.2 liters per minute per meter square of body surface area. Having said that, cardiac output measurement means you have to measure the stroke volume. Stroke volume is measured by measuring the LVOT VTI and LVOT cross-sectional area. Cross-sectional area is measured when the aortic valve is open in mid-systolic position using the inner to inner edge technique. And from there, if you divide the diameter of the LVOT by 2, you get the radius. By using pi r square, you will get the LVOT cross-sectional area. Cross-sectional area into VTI will give the stroke volume, and stroke volume times the cardiac heart rate is the cardiac output. That is one method. The other method which sometimes can be used is to determine the end systolic volume and end diastolic volume. End diastolic volume minus end systolic volume will give the stroke volume. Stroke volume minus the stroke volume times the heart rate again will give the cardiac output. These are the two usually used techniques which can be easily done on the bedside. The volumes of the left ventricle, in terms of systolic and diastolic volumes, are measured using modified Simpson's method.
Okay, thanks for sharing that, Dr.
Oh, well, so the next question is also very important and very interesting about the pulmonary embolism. Most of the time, we have seen that our patients who are ventilated,
Yes.
who are on ventilator, that tachycardia is happening. And
Yeah.
at this situation, the peak pressure, plateau pressure is absolutely normal. And
Correct.
now my saturation going down, my blood pressure falling. Maybe this is a case of pulmonary embolism. So I can't carry my patient to the for a CT scan. So how ultrasound and other parameters can be roped in together to diagnose this pulmonary embolism?
Very, very nice question. The effect of pulmonary embolism of the heart can be twofold. One is it can be direct evidence, where sometimes, not always, sometimes you can see the clot in the main pulmonary artery or the right or left pulmonary artery, sometimes in the right ventricle. If you see a clot there, it is a clear-cut case of pulmonary embolism, especially when associated with unstable hemodynamics or cardiovascular collapse. But most often, what we look for in pulmonary embolism is the indirect signs of pulmonary embolism in terms of right ventricular dilatation. Normally, in the longitudinal axis, the right ventricle is about two-thirds the size of the left ventricle. If it is greater than two-thirds and equal to that of the left ventricular size, it means that right ventricle is dilated mild to moderately, and if it is more than the size of the left ventricle, the right ventricular dysfunction is likely to be more severely affected. So this is one of the parameters which can be used, and also the septum becomes flattened and the left ventricle is D-shaped, which means that it becomes, we express this in terms of eccentricity index. If the eccentricity index is more than 1, it means that the left ventricle is D-shaped, and it indicates right ventricular distension and failure. The other sign which is sometimes described in these patients is called McConnell sign, where the right ventricular free wall contractility is decreased or absent, whereas the apical portion of the right ventricle is vigorously contracting. This is a paradoxical situation which is typically seen in acute pulmonary embolism, but not all patients exhibit this. But if it is present, it is specific to this condition. So these are some of the signs of pulmonary embolism from echocardiography point of view.
Yes, Dr. Burley, right? Fantastic. So that is the way that the message should go, that we can use ultrasound in a much better way to diagnose pulmonary embolism by the bedside, and it can be done, I think, in minutes.
Now coming to yet another very different population, that is obstetric population, pregnant ladies who are presenting to critical care unit or emergency department. Now peripartum cardiomyopathy, I believe to a large extent remains underdiagnosed in obstetric populations, and consequent to the peripartum hemorrhage and this hypertensive disorders of pregnancy. Peripartum cardiomyopathy remains one of the important causes of mortality and morbidity in this population. So how do you think cardiac ultrasound can be used in these patients to diagnose and guide treatment in patients who have suspected to have peripartum cardiomyopathy?
Right. Peripartum cardiomyopathy is a specific condition related to pregnancy which occurs in the last 1 month of the third trimester or the first 5 months after the delivery of the baby, where the LV function is decreased to about 45% or less of EF, and fractional shortening is decreased to less than 30%. Left ventricular end-diastolic diameter is greater than 2.7 centimeters per square meter of body surface area. This, if it occurs in the absence of any structural heart disease or in the absence of previous cardiac disease, is typically diagnostic of peripartum cardiomyopathy. And these in patients who are not doing well, especially when they are hypotensive or their lungs are wet after the delivery or during the peripartum period, one should look for these signs in the by echocardiography.
All right. So, Dr. Moore, your experience about the ultrasound, how it has helped you in saving patients in emergency?
Absolutely wonderful.
certain emergency situations that you
The ultrasound, as already pointed out, is very useful in diagnosing the type of shock, whether it's obstructive, cardiogenic, or distributive shock. And for emergency situations, for example, pneumothorax, the ultrasound as good as X-ray. You don't have to wait for the X-ray to come, so it can be diagnosed bedside just then and there, and therapeutic maneuvers can be done to save the life of the patient. Similarly, pulmonary edema, acute pulmonary edema, this can be again a life-saving therapeutic, diagnostic tool, and also in difficult airway. And if you want to do a cricothyroid puncture with ultrasound, it can be done very quickly and safely, and safeguard the patient's life. These are some of the areas where the ultrasound can be life-saving on the bedside.
I would like to thank Dr. Muralidhar sir for brilliant, ideas and opinions on how we can use cardiac ultrasound to best of our usage in the critical care unit, both in elective and emergency situations, and to save lives, both diagnostic and therapeutic roles. And as Dr. Ranajit rightly said, it's very soon going to be, it is already an adjunct to our stethoscopes in ICU, along with our clinical examinations and assessment always. So thank you very much, Dr. Kanchi and Dr. Ranajit, for facilitating this podcast. Thank you.
Thank you. Thank you for the opportunity. Thank you so much.